today we have an 80-year-old male who is admitted due to septic shock and is on contact precautions due to ESBO of the urine. The patient has a history of cirrhosis of the liver, thrombocytopenia, hypertension, diabetes type 2, hypercholesteremia, and is blind in both eyes secondary to a history of diabetic retinal neuropathy. The patient lives in a long-term care facility and was brought into the emergency room by the daughter, being that she is closest to him according to her. As per the patient's daughter, the patient had a drastic change of behavior from Monday, December 6th to Wednesday, December 8th. The daughter states that the patient is usually self-ambulatory with a lively spirit and is now unresponsive and unarousable. The patient is a full code but DNI, and the family prefers emergency medications but no compressions. The patient's heart rate is currently in the high 50s to mid 60s with a blood pressure of 98/72 and is currently maxed out on levofen and vasopressin, which are infusing via an intrajugular cordis to sustain an adequate MAP of 65 or greater. The patient's oxygen saturation is currently 96% and is on oxygen at 30 liters per minute via nasal cannula. Their temperature is 97.8 degrees Fahrenheit, and the patient is currently unresponsive to pain and unarousable. The patient is unable to follow simple commands. Pupils are bilaterally 2 millimeters and are non-reactive to light. They are round, non-accommodating, and the patient's oral mucosa is pale, dry, and intact. The oral care is performed every 2 hours. The patient's trachea is without deviation. Skin turgor is poor with tenting present in the upper clavicular area, and the patient's upper extremities are weeping a serosanguinous fluid and are edematous with an erythematous color and are cool to the touch with a +1 thready radial pulse bilaterally and have a capillary refill of 4 seconds. The patient's lung sounds are diminished in the upper lobes bilaterally with crackles present in the lower lobes bilaterally. There is equal chest expansion. The patient has normal active bowel sounds in all 4 quadrants and is on vital liquid feedings at 40 mL per hour via an NG tube, which is secured at 55 centimeters from the left nair. The patient has had 2 bowel movements today. The patient also has a 14 French indwelling Foley urinary catheter, which had a total of 600 milliliters of output all day today, and Foley care was performed today at around 900. The patient's lower extremities are without edema, are pale and cool to the touch, and the pedal pulses are a thready and +1. And they have a capillary refill of 4 seconds. The patient has a right midline in the upper arm in the basilic vein, which has only 0.9% normal saline running at 125 mL per hour, and an intrajugular cordis catheter which is being used to infuse 25 micrograms of levofen per hour, and vasopressin which is running at 4 units per hour. As per Dr. N's diagnosis of the refractory shock, I feel it is best to have case management present the option of hospice care while respecting the family's decision to continue care if desired.